So I'm David Amponsah, ultrasound director at Henry Ford Hospital in Detroit, Michigan, and would like to thank SAEM, the organizers, for giving us this opportunity to present or share some of our ideas about how we can fulfill the EM ultrasound milestones, particularly focusing on the 18-month system-based ultrasound curriculum that we've developed at our institution, Henry Ford Hospital in downtown Detroit. So I'm actually going to give a brief overview, and the bulk of the content will be presented by our ultrasound fellow, Dr. Randi Connor-Schuler, followed by our associate ultrasound director, Dr. Julian Suszanski, and Dr. Dowers. She's physically here but currently ill, so we have one of our core faculty, Dr. Dan Morris, that's going to fill in for her. All right, in terms of disclosures, we don't have anything to disclose for the content of this educational activity. And in terms of the core content areas, I just want to focus briefly on the background as to how we came up with this organ systems approach to fulfill the EM milestones. We'll also talk about or describe one of our sample curriculum documents, basically focusing on the head and neck portion, which basically is about a fifth of what this whole systems-based approach curriculum essentially entails. We'll also talk about successful implementation of this curriculum and also some of the assessment methods and how it seamlessly flows into the fulfillment of the milestones, and leave some time for questions and answers. So these instructional objectives have essentially been written based on the core content that I just talked about, so you can read them off the slide. But in terms of the background, how do we actually come up with this systems-based approach to fulfill the EM ultrasound milestones? This is as a result of our significant experience teaching medical students at the undergraduate level at Wayne State University School of Medicine, currently in our 13th year. And we've been able to determine that looking at the current model and the new model that we're going to be proposing, it provides a seamless way of actually teaching residents starting from the undergraduate level, a seamless continuum of an ultrasound curriculum that can be essentially extended all the way to the postgraduate fellowship level. So that's what we're going to focus on. So what's currently in existence? So most ultrasound programs essentially have different curriculum documents based on these. So the ACGM ABEM milestones published first in 2012 as the PC12 and a PC14 focusing on procedural applications. But what's been the standard or the template that most departments have been using have been the ACEP ultrasound guidelines or the statement policies. So the first one in 2001, updated in 2008, and currently in 2016, there are about 12 core applications. So with the PC12, or the Patient Care 12 subcompetency developed by ABEM, ACGME, ultrasound directors essentially found some difficulties with the application of these levels of competencies amongst residents. Because if you focus on PC12 level 5, most residency programs can actually not achieve this competency before residents graduate. You know, advanced echo, as Dr. Favit presented, strain and what have you, or TEE and other applications. So there was a subcommittee or a group of ultrasound leaders representing different organizations, ACEP, CORD, and SAEM. They came together and revised the original PC12 milestones with the goal of providing ultrasound educators an ability to better assess resident competencies in a uniform way from year 1 to 3, to be able to track their competencies in the progression as well as their performance of ultrasound. And you can actually get a copy of that if you just use your iPhone to capture that QR code. And what has been the template for most programs essentially is the ACEP policy guidelines, so you can also get that with a QR code by just using your cameras. So this list seems to be expanding. Going back to 2001, there were about 6 or 7 core applications, and it's increasing and increasing, and it will probably get up to a list of about 20 over time as we add more complicated or complex applications to it. What's important to note is all these core applications are based on 5 functional clinical categories. So based on the resuscitation aspects of ultrasound assessment, diagnostic, procedural guidance, all the way to therapeutic ultrasound, they've come up with these core applications, which basically assist ultrasound directors to develop curriculum documents based on it. So this is what we're actually proposing, and this has to do with our experience with teaching ultrasound at the undergraduate level and figuring out that it's actually a unique way of developing a curriculum document that would provide a seamless continuum of ultrasound education from the undergraduate, preclinical, clinical, to the graduate resident level, and to the postgraduate fellowship level without doing a lot of significant changes in terms of the ultrasound curriculum. And these would also be based on those 5 functional clinical categories that I talked about. And in terms of the detail of each of these specific categories, essentially encompasses all the core applications that are essentially identified in the ACEP guidelines as well as the EM milestones. So what I'm going to do is I'll turn it over to our ultrasound fellow who's going to provide a little bit more detail regarding how the ultrasound curriculum has actually been implemented. So Dr. Randi Connor-Schuler.
All right, thank you for that, Dr. Amponsah. So like he said, I'm Randi Connor-Schuler. I'm the fellow at Henry Ford Hospital, and so I'm going to be going more in depth onto our ultrasound curriculum. Overall, our residents complete rotations in ultrasound. So as an intern, they have a mandatory rotation. As a PGY3 or a senior resident, they have an optional elective. Interns also will complete an introductory boot camp for POCUS when they arrive in residency. Residents also complete asynchronous learning through simulation modules throughout residency. Furthermore, we have dedicated ultrasound simulation sessions during grand rounds time that are scattered throughout the year. We have dedicated musculoskeletal grand rounds time where we do MSK ultrasound, and this is done in conjunction with the sports medicine, emergency medicine faculty. And so we have 5 of these sessions scattered throughout the period, each of which focuses on one joint, and we have 3 30-minute scanning sessions split by PGY level. All of this training is done with case-based learning, and scanning is involved on live models, and so we usually will present a case, have the residents scan on a live model so that they learn proper technique and normal anatomy, and then we have PowerPoint review for pathology. So for example, we would give them a case of a 61-year-old male who presents with traumatic left knee pain, and we would tell them, let's go scan the right knee, and they would practice scanning on a live model, right knee anatomy, which should be normal in a practice model. And so they would go through transverse, longitudinal axes, looking at the patella, the quadriceps tendon, looking for effusions in the prepatellar space. And then we would go back to the case and show them some pathology. So as shown here, we would show them a quadriceps tendon rupture and talk about the findings there. And other examples for the knee joint would include a patella fracture, hemarthroses, joint effusions. Particularly for the interns, we also have a phantom, and so they can go through practicing knee arthrocentesis through simulation as well. For our POCUS sessions, we have 7 sessions that cover 10 anatomic sections, and this is divided over 18 months. And so we go in an anatomic systems-based approach for this in head-to-toe fashion. These sessions are each an hour long, so a total of 3 hours in each of these with hands-on scanning time divided into PGY level. And again, this utilizes case-based learning, and we implement live models for scanning of normal anatomy, as well as lectures for going through pathology. This lists all of our anatomic systems, which again goes in head-to-toe fashion, and we broke them down as you see on the screen. We do head and neck, which we'll go into in a little bit further depth later. Cardiorespiratory system, we do cover the cardiac and lung together in one session. Interns will get basic PASS protocol, basic cardiac windows, and then by the time they're PGY3, this time will be spent on more advanced calculations and applications. We have a dedicated trauma sim day, and so that is when we'll utilize mainly the FAST exam throughout that session. where interns will be focused on technique and learning how to obtain the appropriate views, and then seniors will get more advanced image interpretation and pathology for clinical implementation. The upper and lower extremities will be done during the MSK sessions that are in the separate 5 sessions. We also have a shock day, similar to our trauma day, in which we'll go over protocols and volume responsiveness. Again, that'll range on PGY1 level. And PGY1 levels will do IVC assessment and limitations, and then seniors will do more advanced applications, again, such as VTI and carotid flow time. And then we have one session where we focus on review of anatomy and do jeopardy in cases. All of our anatomic systems have a scanning protocol in place, and we go through all of these with case-based learning, and we use live models and simulation for training for each of these. I'm going to go through the head and neck system as an example of how we implement this. This is an overview of our core clinical content, each of which has specific objectives, and each of these are designed so that residents will be trained to achieve competency in each of those functional clinical categories. So PGY1, they're more focused on learning for head and neck all of the different structures and how to scan them. And so they'll do an overview of ocular, the vessels, the glands. They'll learn to identify the trachea and esophagus, and they'll get an introduction to identifying the brachial plexus and for central line placement. The second years at our institution are when they start to rotate through our Category 1 area, which is our higher acuity area. And so this is when they start to intubate patients, and they'll do more procedures. And so that's why we'll start to focus more procedural-based applications for them, such as airway assessment and NG tube placement, as well as more advanced applications for central line placement. For PGY3 level, they're focused almost solely at this point on more advanced applications, and so we'll be covering interscaling blocks as well as subclavian lines. This is an example of our overall structure. So they go through all of this. They'll start just with plugging in your information in the computer to selecting the correct transducer for each study and getting the right preset on the ultrasound machine. For each of those systems, we list all of the structures, patient positioning for them, and go through each of them in short and long axis. We also, for example, when we get to the point where we're talking about the interscaling block, we'll talk about the clinical implications for this, which patients you do and do not want to do this on, contraindications. So for example, when we're talking about ocular, everybody will go through the basic scanning and technique all the way from placing a tegaderm and how to hold the probe and the scanning protocol. They'll go through identifying normal anatomy. And then everybody will be instructed on the contraindications for these scans, such as not doing them in cases of concern for globe rupture. Interns will get an overview of essential and pathology such as retinal detachment and vitreous hemorrhage for this, and once residents get to a PGY3 level, they'll be exposed to more rare pathology such as a cataract or asteroid hyalosis or, as in this case, a funnel retinal detachment. We also go through central line placement with everybody. Again, interns will get an introductory course. Second years may talk more about short axis versus long axis, in plane, out of plane. And then by the time they're PGY3 level, we'll focus more on doing rare applications such as subclavian lines. And we also have a phantom that they can practice on as well. For ET tube placement, since we can't do this live on live models, most of this is going to be based on image review. And we go through both dynamic and static approaches, successful and not successful intubations based mainly on image clips. As part of the therapeutic component, we go through resuscitation, and so one of the things they'll look at is IJ distensibility. All the residents go through at least one rotation their intern year now with our department, and so they'll do 1 to 2 weeks in conjunction with their anesthesiology rotation. And because they're working clinical shifts in the emergency department, they're scanning is limited to 3 hours per day here, and this is really just to get a basic introduction and background skills so that they feel more comfortable picking up their probe when they go to work in the emergency department throughout their 3 years of residency. As a senior, we have an optional ultrasound elective that is anywhere from 2 to 4 weeks. This is a bit more intensive for the residents, and so they'll be scanning 6 to 8 hours a day. The goal of getting at least 15 scans a day and at least 150 scans to meet the ACEP certification. In addition to honing and refining their image capture skills, we also really focus on their image interpretation at this point. And so they are expected to attend any QA sessions as well as submit any scans that they perform for QA with full review. They also, at this point, need to be completing the asynchronous simulation models that we have throughout residency, and they're involved in teaching both the interns and medical students that are on their rotation. All right, and so to further talk about how we implemented this program, I'll give you Dr. Julian Suszanski.
Thank you, Randy. So Dr. Amponsah has presented to you our kind of overall structure of taking a anatomical or systems-based approach to describing the curriculum. And then Randy has taken you into the weeds to kind of really give you a descriptive model of how the resident ultrasound experience is at Henry Ford Hospital. I'm here to talk to you about the nuts and bolts of implementing that program, some challenges we faced, and kind of resources that we had available and able to put this in place. So to begin with, when we decided to revisit the curriculum and change it, we already had an established strong ultrasound curriculum within the residency program and within the Department of Emergency Medicine. We had a group of core faculty who were dedicated to teaching the residents. And we had a program that is very responsive to resident feedback. They're always trying to make the program better, and the residents recognize the efforts of the ultrasound faculty, and we're constantly requesting more time with ultrasound and more sim time built into the session. At the same time, we had a change in residency leadership, and I bring this up not to say that the previous leadership was not supportive of ultrasound efforts, but it just led to an overall sense of change in the air, and it was easy to suggest or provided a nice opportunity to suggest change within curriculum and within rotations. So the previous experience before what Randy described was slightly different. The residents, through their 3 PGY years, were given graduated ultrasound goals, which they were expected to meet. We only had 4 sim sessions a year, 3 of which ultrasound was included in. And these were theme-based sim sessions, themes like surgery and trauma, or cardiorespiratory emergencies, or toxicology. We would incorporate ultrasound into these sessions. We also had 2 citywide ultrasound symposiums per year where we gathered with local experts, such as the previous presenters, Dr. Favit and his group, and we'd all get together to focus on the basics as well as high-end topics that the ultrasound community was facing. They had a smattering of didactic lectures built into their grand rounds, and then the PGY3s had the optional ultrasound elective. So in order to change the curriculum, we had some valuable assets in place. First and foremost, we had Dr. David Amponsah, who spent a lot of his time implementing a very robust ultrasound curriculum and establishing point-of-care ultrasound within our hospital. We also have a robust ultrasound faculty. Currently, we have 5 fellowship-level trained individuals who serve as our core faculty, and in addition, we have 5 faculty who are dedicated to bringing point-of-care ultrasound to the emergency medicine residency. We have an emergency ultrasound fellowship, and this gives us a lot of flexibility. Not only do staff and residents see the fellow scanning bedside throughout the department day to day and augmenting medical decision-making based on findings, but the fellow also has a very flexible schedule which can help fine-tune teaching events when learners' schedules changes. We have a multi-million-dollar sim center in the basement of our hospital which we have access to, which provides an excellent learning environment for practicing ultrasound. And in terms of just hardware, we have 8 ultrasound systems within our emergency department, and we have access to additional 5 ultrasound systems that are housed within the sim center, which means it's always possible to get your hands on a machine and find a place to teach residents. So the major changes when implementing the new curriculum was that sim time was increased to 8 sessions per year. So you can imagine I think all of us who are educators here feel that today's learners really benefit from small group environments and hands-on teaching sessions as opposed to the didactic module. But it puts a significant strain on your faculty. We have 8 sim sessions a year, and we have the 5 ortho small groups. That means that we need 4 ultrasound core faculty members available almost on a bi-monthly basis to teach these residents. And we're fortunate to have the dedication of the staff to do that. We also added an additional PGY1 ultrasound rotation, which means in a busy schedule, we had to find a time to slot in that PG1 experience. And we were able to do that with the anesthesia module. And the other main change that the residents faced was previously the asynchronous learning from the simulation models that are available online was optional. And we now made that mandatory. And to me, that was one of the biggest changes that I liked, because now I could track their outside learning abilities. So as I mentioned, we found that time for the PGY1 rotation. You already are aware that we partnered with ortho and sports medicine to be able to incorporate the MSK teaching into the sim sessions. But 2 of the other challenges that we still see is, number one, when we started the sim sessions, residents were very hesitant to scan one another. Oftentimes, when we all got to the bedside, there would be awkward glances left and right about who was going to take off their shirt and lay on the bed to let us scan them. So the way we solve that is we now employ models who come for 4 hours during our teaching sessions to allow for scanning. The other major barrier, and I think this is universal, that everybody who practices emergency medicine faces, particularly in a tertiary hospital, is that it's very easy to hop on to your EMR, click a couple buttons, and order a formal ultrasound study when the day is busy. And even though we can teach very well in these sim sessions and everybody's eager to learn, getting them to then bring that up to the bedside and implement it on a busy shift is always a challenge. But my answer to that is that every month in QPath, we see more and more ultrasound being performed, so I think we're getting our message through. Everybody wants to know about cost when you implement an ultrasound curriculum, and how much is this costing. So first of all, we did purchase asynchronous learning module. There are multiple vendors that you can utilize. The exhibit hall is fantastic. Many of them are here today, and so if you're interested in finding out the price, I encourage you to go visit them at their booths. For the live models, we pay them $25 an hour. These are young, healthy models. In general, they have no pathological findings. Every once in a while, you get a surprise. In terms of phantoms, we're very fortunate to have the Sim Center. The Sim Center purchases and maintains the vast majority of the phantoms we use. In the emergency department, we have purchased a pelvic phantom to simulate transvaginal ultrasound, and we've also purchased a handful of ultrasound peripheral IV blocks. And then finally, I mentioned this puts a large burden on faculty time. And all I can tell you is that we have a very dedicated group that's willing to donate their time to these efforts. None of us are sitting on a pot of gold at this time. I'd now like to turn it over to Dr. Dan Morris, who's going to tell you a little bit about competency assessment.
Thanks for that introduction. I'm pinch hitting for Dr. Dowers, who is sick, and we all wish her a speedy recovery. I'll be talking about competency assessment and how do we make sure that the residents, which we are sending out into the world, know what they're doing. So the ACGME originally outlined ultrasound milestones for emergency medicine residents. This was put through the PC-12 goal-directed focus ultrasound, which was basically milestones for those areas which they need to be competent in. One area in which we found that a lot of residents were not fulfilling was the subgroup of the PC-14, and that was starting peripheral IVs through ultrasound-guided IVs. And that's, so what we did is we needed to focus on that in order for them to improve those guidelines and milestones. You can go ahead and scan this icon up here to take a look at those guidelines. So we have a clinical competency committee, and how do we adjudicate these, whether these milestones are met? So the residency committee meets every 3 months, and in most milestones, the residents have to demonstrate that they can achieve. Usually they have to do this at least 5 times. So we did 5 intubations, 5 central lines, ultrasounded central lines. They have to demonstrate that at least 5 times. Now, how do we collect this data? This data is collected through a resident procedure log. It's also through QPath. They're able to record their images. And we also have what's called an online wire, where we can either check off if they achieve a milestone, or we can handwrite what they've done, specifically if they've attended their Grand Round lectures, or if they've attended their SAEM resident education lectures. Anyhow, so what the clinical committee does is they meet and then they summarize what they've done, and then we're able to identify whether they're lacking achievement of these milestones, specifically like in ultrasound guided IVs. Now, in order to make up for these deficits, that we would hold grand rounds, as Dr. Suszanski mentioned, where we would have a specifically dedicated area where they would practice and we would teach. So like with peripheral guided IV, we would have like a hour session for each first, second, and third year, and make sure that they know how to cannulate ultrasound guided IVs on mannequins. So because of this, as Dr. Amponsah mentioned, there's going to be some revisions to the PC-12 guidelines, because originally they weren't really made by ultrasound faculty, and our group basically supports these changes. And again, you can get those guidelines through scanning the QR icon here. In addition, ACEP has its own guidelines. They basically said, you know, you have to do between 100 to 300 scans, not really focus on any specific area. And they had 2 pathways. They had a residency pathway, and then they had a practicing pathway for those physicians who never went through a residency, which formally trained, didn't have training through a residency program of ultrasound. Like myself, I mean, I had to learn ultrasound all on my own and through my esteemed colleagues here. Now, how do we assess that there's the competency? How do we know that when we send a resident out that they know what they're doing? So we do this through a couple different factors. We have OSCE evaluations. We specifically look at how their basic technique is, how they're acquiring images, how they're orienting the probe, how they're holding the probe, and how they're optimizing images. We also make sure that when we have these models that we talked about in our sim sessions, that we make sure that all their views they all have good views, because as you know, ultrasound is body habitus dependent. And so we make sure that each model has good views that a competent physician should be able to get, that they're able to do right upper quadrant, be able to do a fast exam, be able to identify the gallbladder and any associated stones. And then finally, these are all evaluated by the faculty. So in terms of competency assessment, how do we, how is this done? So each resident will do their scans. They will send it through QPath, and through a QA process, they will, when they do their scan in real time, they will decide whether, you know, this is a normal scan, whether this is abnormal. Do they have ejection fractions, which, you know, does this patient has abnormal ejection fraction? Does this patient have gallstones? These are all real time that they perform. You know, we don't hand out multiple choice tests, and so we're able to review these and actually find out exactly whether they're able to capture these scans. Now, in terms of, this is just something that we've decided that we're toying around with, of like, how do we scan, how do we grade a resident? So there's 4 basic ways for ultrasound image acquisition and identification, and that's through basic techniques, how you hold the probe, how you orient the probe, your image acquisition, and how you optimize it. And we would give a point for each one of these. And if they got 3 out of 4 of these, then we would, they would be 75%, and then we would say that, well, okay, that's the minimum. We're going to let you miss one, and then with basically a pass-fail type of grading system. And with that, I will turn this back over to Dr. Amponsah so he can do a summary.
Thank you, Dr. Morris, for filling in for Dr. Dowers. And so in summarizing what all the speakers have talked about, basically looking at the current model in terms of ultrasound curriculum documents that individual programs have developed and are developing, they're essentially based on the EMPC 12 and 14 milestones, as well as the ACEP policy guidelines. But we think probably the best way moving forward, thinking outside the box, is with the experience that we've had at the undergraduate level, using a kind of a systems-based approach to capture all, for instance, the core applications listed in the ACEP policy guidelines. Using a systems-based approach can generate all those lists in addition to an exhaustive list of what learners need to know as residents. So proposing this new curriculum would make it essentially possible to create this seamless continuum of learning from the undergraduate level all the way to the fellowship level without a lot of change, because in terms of the directors that are essentially leading the way, most of us are emergency physicians at the undergrad level all the way to the fellowship level for point-of-care ultrasound. So what I'm going to do is I'll leave it up to you for questions at this point. If you have any questions, we'll be glad to address them. Doctor?
Who pays for the models? Does it come out of like the residency budget?
Yes, so at our institution, we also have what we call the Henry Ford Ultrasound University. So we have an institution essentially at learning a CME-based program actually created under the Department of Surgery initially in 2008. So learners that take these courses actually get CME credits through the American College of Surgery. And what we do is the money that we generate from these courses that others come over to essentially sit for as learning ultrasound, we use that money in conjunction with what the residency basically has to pay for the models. So we essentially pay for it as an ultrasound group, but it's in conjunction with what the department also. Yeah, yes, yes.
And it's $25 an hour?
$25 an hour for models, and so for a sim session, we normally have at least 4 models. And in terms of the learner to instructor ratio, we normally make sure we have no more than 3 learners to 1 instructor for the best hands-on, and the max will be 4. So for these paid courses through the Henry Ford Ultrasound University, we could normally go up to about 4 learners to 1 instructor, but the ideal from what we've noticed, it's like 3 learners to 1 instructor. So we have the number of models to just accommodate for that. Any more questions? Yes?
Sure. So as you're changing to a more system-based approach,
Yes.
are you integrating that to coincide at the same time with the regular didactics that the residents are getting?
Yes, so
Learning that head and neck in the regular didactics?
So it has to do with the whole structure of how the residents are essentially taught. So the sim sessions, these are theme-based, as Dr. Suszanski talked about, because we could have like a trauma-based session. So during that time, we can focus on, let's say, abdomen, trauma, or focus on the FAST. And your question again, specifically, you were trying to figure out exactly what?
I guess, at least in our shop, we have our regular typical topics days.
Yes.
Our Wednesday conferences, and maybe, hematology for 2 weeks or 3 weeks, and then, head and neck pathology.
So how do we integrate ultrasound into all that?
Coinciding at the same time?
Yes, so if we have these sessions at the Sim Center, like the simulation sessions, they're general topics. So it could be pediatrics. We're going to find pediatric ultrasound applications and teach residents at that particular time. But even the objectives based on the core content of what needs to be taught, we can focus on specific areas for each PGY class. So if we're doing head and neck, the PGY 1 class will focus on image capture of just simple identifying structures in the head and neck. Second years would focus a little bit more on the procedural applications, and third year recognition of pathology, because they would have already gone through those other pre-training levels to get to the higher level of learning. Within each of those, yes, subcategories. So if you're doing head and neck, we divide it even based on that. And this takes it all the way to the preclinical, even undergraduate level. So if it's head and neck for year 1 medical students, an example of a test question that we have in the gross anatomy exam and it's integrated into their gross anatomy course and taught concurrently during each of the gross anatomy sessions. So if they're doing head and neck, for instance, a first-year med student as part of their head and neck final exam would see an ultrasound image-based question, which, for instance, would show an image of the inner scaling groove with the brachial plexus, and they would see the anterior scaling, middle scaling. The question for a first-year med student is to identify the anterior scaling muscle. So to properly identify that, you have to also look at the sternocleidomastoid, because the SCM is, the anterior scaling is just deep to the sternocleidomastoid, and the middle scaling is lateral to it. So that would be a core content area for a first-year med student, but that's essentially in line with the same curriculum document, which can be expanded all the way to the graduate level depending on what you want to teach. So the fellow will be performing an inner scaling block, or a resident will be doing that, but the first year will be recognizing these structures. Or you can pose a question about what's the echo signature of a musculoskeletal structure like muscle in short axis. So it's stereonite. Or if it's in long axis, it's pennate. So it all depends on what you want to teach under each of those systems. So it starts with the core content, and based on the core content, you develop specific objectives depending on the level of training. So it doesn't change. So that basic structure allows for a seamless continuum of learning from the preclinical, clinical, graduate resident level to postgraduate fellowship level. And with emergency physicians as leaders in this area, it makes it a lot easier to do that as opposed to coming up with an exhaustive list of core applications and keep adding and adding to it. So, and that's worked over the years, but I think a much better format will be rethinking or thinking outside the box and coming up with this global way of looking at ultrasound education and making it a lot easier to implement it. Okay, so I'll let the others also comment on it, but this also has to do with those who've had undergraduate ultrasound experience, because there are a number of medical schools that are teaching medical students some basic ultrasound skills. Those that go to or attend Wayne State, they're fortunate enough that the first 2 years they get a lot of significant ultrasound, but it kind of falls up in the third year, and they kind of pick it up again in the fourth year, depending on which clinical site they're rotating at. So students who've had, so they basically come in as first-year residents with a heterogeneous level of, in terms of ultrasound exposure. So what we do is we have a dedicated month, July, when they become new residents, and we give them like an immersion of learning as emergency physicians. So we reset everything for them, and that includes a 2-day point-of-care course, a 1-day focus on procedural applications to get everybody to start thinking as emergency physicians before implementing this curriculum that's essentially been designed. And if anyone has any comments. Yeah. Yes, so it's like regardless of what you've learned as a medical student, we're going to start you all the same level and get you to think as emergency physicians. This is ultrasound, and some come with some level of experience and others with no experience whatsoever. So we reset everything during the month of July before implementing this curriculum based on those specific levels of learning. So the good thing about it is if you were to select any of these systems or anatomic regions, so if you say, we just finished a unit, pelvis, with the first-year med students. So for the pelvic unit, we presented a case of a patient with blood at the urethral meatus. So the focus for a first-year medical student is not, all right, what am I going to do with this patient? Okay, retrograde, urethrogram, or what? So you're not going to put a Foley in. So that's not your focus. What we focused on for that objective was, why is the patient, so a high right-in prostate, why would a patient have that? It's because they normally have a disruption of the puboprostatic ligament resulting from a pelvic fracture. So which part of the urethra also gets damaged as a result of that? And so it's a membranous urethra. So they need to know all the 4 parts of the male urethra and figure out which part actually gets damaged when the puboprostatic ligament gets disrupted, causing an elevation. So that's the high right-in prostate. So it's in their anatomy text. But we normally bring this like a front-loading effect during these ultrasound sessions to teach that part of it, so as they graduate on to become residents, they can go back and link those two in a way. So having that structure, using those systems, makes it a lot easier, but what you need to focus on in terms of the learner that you're teaching has to be exactly what you want to convey to that learner at that particular level. So as mentioned with the head and neck example, interscaling, identifying the muscle ecotexture or which specific muscle it is. You ask a third-year resident, they would not know that because they forget all that anatomy. The first-year resident will remember it, or at least they need to know it to pass your exam. So once you have that continuum of learning, you become a better physician as well, because at the bedside, when you're doing your physical exams, you actually remember a lot of these anatomic structures, which helps you a lot to even interact with consultants and what have you. So the goal is we're going to write this up and make it a new curriculum design for EM resident training. Thank you all.